This presentation will cover epilepsy. I'm Bethany Von Hoff and I will be the presenter today. Like many of the other presentations in this section, we'll be covering epilepsy in a broad overview. Epilepsy can be a very difficult condition to treat, and there can be many patient-specific issues that affect treatment. The goal for treating epilepsy is to maximize the number of people who reach their therapy goals. When you are targeting and manipulating the central nervous system, the drug therapies you choose have a different level of human impact, and so the decisions must be made very carefully and with consideration. In this presentation, we will cover the basic background of seizures and talk about some of the medications used for the treatment and the associated side effects and when you might choose one medication over another. We will also talk briefly about special situations when treating epilepsy, such as pregnancy and when you may discontinue anti-epileptic therapy. In the most basic terms, a seizure is a malfunctioning of the firing of neurons in the brain. This malfunctioning leads to a disorganized, non-purposeful firing that leads to a seizure. It's important to recognize that people can have seizures, but that does not mean that they have the disease epilepsy. Epilepsy is a disease or disorder of the brain that is characterized by periods of unpredictable seizures. Thinking about the pathophysiology of seizures again, it's thought that they arise from the rapid firing of neurons in the cerebral cortex. Patients who have epilepsy often have a family history of epilepsy or seizures, so perhaps there may be a genetic component that affects a person's seizure threshold. For example, someone may have a seizure at a certain temperature and someone else wouldn't, and this could have a genetic origin. Many brain functions are involved in or impacted by seizure activity, including memory, attention, perceptual awareness, thinking, language, and consciousness. Secondary seizures are seizures caused by something identifiable. So if someone is in a traumatic accident or a car accident, for example, or if there's a stroke or infection in the central nervous system, certain tumors or certain drugs in overdose or withdrawal can cause seizures. Basically, you can see on this list that there are many reasons why a person can have a seizure, and if we have an identifiable cause, it's known as a secondary seizure. Also remember, just because a person has a seizure from one of these known reasons does not mean that they will necessarily go on to develop epilepsy, and this is a very important distinction. Seizures are classified into generalized seizures and partial seizures. Generalized seizures are ones that begin in one area of the brain, but then spread to both hemispheres of the brain and can affect other brain areas, for example, the thalamus. Partial seizures are also sometimes called focal seizures because they start in one area of the brain and they do not spread. The symptoms are related to the area of the brain that the seizure activity is occurring in. Often when we're talking about generalized seizures, we are referring to tonic-clonic seizures. This is often the stereotypical seizure that you might see in a movie or a TV show. They used to be referred to as grand mal seizures, but the correct terminology is tonic-clonic seizure because of the intense tonic-clonic muscle contractions. These seizures are associated with a loss of consciousness and usually a period following of exhaustion and confusion. While this might be the seizure that most people think about when they hear the term seizure, there are several other kinds of seizures as well. Myoclonic is typically a secondary seizure consisting of short, sporadic periods of muscle contraction. There are also febrile seizures, which also involve convulsions, but these are seizures that are associated with high fevers, usually self-limiting, and you often see this in children. But again, these children do not usually go on to develop epilepsy. Absence seizures involve a brief loss of consciousness, and often it can look like a person is zoning out or daydreaming. I encourage you to look up this kind of seizure online and look at a video of what the absence seizure looks like. It's very different from what the typical seizure you think of is. The last type of generalized seizure is status epilepticus. This is a life-threatening episode of back-to-back seizures. the seizure activity does not stop, and this can lead quickly to brain damage and death. As a reminder, partial seizures are when the seizure activity is localized to one area of the brain that does not spread. Partial seizures can be broken down further into simple and complex partial seizures. The main difference is whether or not there is a loss of consciousness. In simple partial seizures, there is no loss of consciousness, and usually there is just a single muscle movement or sensory alteration. This might be the jerking of one arm, for example. In a complex partial seizure, there is a loss of consciousness, and it's generally anywhere from 30 seconds to 2 minutes, and it may also involve changes in motor function. A patient may lose control of their bowels or urinary function, or may have involuntary movements such as lip smacking or hand wringing. Now that we've touched on the background of seizures, we're going to talk about some of the agents that we use to treat epilepsy. The drugs are broken up into first-generation and second-generation agents. When we talk about generations of drugs, the first generation usually means that they were the first medications on the market used for this disease or condition. And when we say second generation, it means that they are the newer agents on the market. So those listed on the left-hand side for the first generation are agents that have been around a lot longer, which also means that we have a lot more experience with these medications. The agents listed at the bottom of the second generation list will not be tested on, but they are provided for completeness. The agents used to suppress and prevent seizure activity work through two common mechanisms. They often either affect the sodium channels to decrease the rapid firing of neurons, or they work to enhance GABA, which, as you remember, is the primary inhibitory neurotransmitter. Agents that work through the sodium channels include hydantoins such as phenytoin, carbamazepine, and lamotrigine. And agents that work by enhancing GABA include valproic acid, benzodiazepines such as diazepam, and gabapentin. There are some agents that do have a unique mechanism of action that doesn't fall into the two broad categories mentioned on the previous slide. The first is ethosuximide, which modulates the neurons in the thalamus, and topiramate, which is responsible for influencing multiple things. These are the proposed mechanism of action, but we aren't 100% sure that this is all that these medications do, or that these are the primary reasons why they are effective in preventing seizures. There's some uncertainty around these agents, so we've provided what's the most commonly believed mechanism of action for simplification, but we know that it's likely more complex than this and not fully understood. Now we will start talking about some specific agents and their associated side effects. Phenytoin, which goes by the brand name Dilantin, is a very common agent that has been used for a long time. The primary side effect is a rash. You'll see throughout this presentation that rash is a common side effect for many of these agents, as well as CNS side effects, which makes sense if you think about how these medications work. They are interfering with brain functioning, and they are trying to quiet or inhibit the overactive neuron firing, so it makes sense to think about some of the main side effects being drowsiness, impaired cognition, and maybe some memory issues. So it's important to understand why this is a reasonable and consistent side effect associated with how the medication works. In addition, phenytoin has some unique side effects, including gingival hyperplasia, which you can see on the picture on the right, which is an overgrowth of gum tissue. Hirsutism, which is an increased body hair growth in women, and there's a risk of liver toxicity and osteomalacia. Patients who are on phenytoin waste vitamin D and folic acid and may need supplementation. Phenytoin has some interesting challenges when it comes to dosing. Phenytoin has non-linear kinetics, so what that means is that if you double the dose, you do not get double the concentration. Depending on where you are on the curve, You may see a small increase in concentration, or you might get an exponential increase in concentration. The drug is highly protein bound, so the drug very easily gets bound to proteins, and it's only the free drug that is active. So depending on a person's albumin level, which is a protein, you may see higher amounts of drug in the body, which could lead to toxicity. This is also important in patients with renal disorders because they tend to have lower albumin levels or malformed albumin that doesn't do as good of a job of binding other substances. This agent is also metabolized by and is an inducer for some of the CYP enzymes, so it's a complicated medication. So on the picture on the right, in a linear drug, if we double the dose, we would get double the concentration, so it'd be very easy to predict. But because phenytoin is nonlinear, it's not as easy to predict, and so we need to monitor blood levels to make sure that we're getting enough drug for it to be efficacious, but not too much that it's unsafe or toxic. Tegretol, or carbamazepine, is another common agent that we've been using for a long time. This agent also has a side effect of rash, but it's different than the rash seen with phenytoin. This is a delayed onset rash, meaning it can take a while before it shows up. Also, this rash can be life-threatening. You'll again see that this agent has some CNS side effects. A unique side effect to carbamazepine is SIADH, which stands for the Syndrome of Inappropriate Antidiuretic Hormone. So patients who take carbamazepine need to monitor their sodium levels closely to make sure they are not developing this syndrome. Monitoring the blood concentrations is also required with carbamazepine like we do with phenytoin. Carbamazepine also has some of its own unique dosing challenges. Carbamazepine is metabolized by CYP enzymes in the liver, and it also induces its own metabolism, and that can take a while for the enzymes to plateau, usually 3 to 5 weeks. So what that means is that when the enzymes first start to see the drug, it metabolizes it faster in the first few weeks. So in the first few weeks, you need to be especially careful that the patient is staying in the therapeutic range, but then the levels tend to plateau. Because it induces these enzymes, it can also induce the metabolism of other medications, and it also can be influenced by other medications that use these CYP enzymes. This drug is also protein bound, less so than phenytoin, but it still can be affected by albumin levels. Lamictal is a second-generation agent. Again, you see rash and CNS side effects as potential side effects, and this ends up being a pretty consistent adverse event profile. Lamictal can also cause nausea, vomiting, and weight loss. There's also been reports of acute multi-organ failure with this agent, so we're very careful to monitor and use an extreme caution with someone who already has end organ dysfunction. Valproic acid is another commonly used drug. Side effects include tremor, hair loss, weight gain, and also liver toxicity. Also, patients who take this medication can also get severe acne, which may make some patients not want to take this medication. Valproic acid is also metabolized by the CYP enzymes, but it also inhibits the CYP P450 enzymes. Benzodiazepines work really well to inhibit unwanted rapid firing of neurons, and we've talked about benzos prior to this presentation, but just remember to think about how these agents work. They enhance the GABA system, so some of the main side effects are also their wanted effects, including sedation and drowsiness, but sometimes you also can see some amnesia. We only use these agents acutely for treatment or prevention of status epilepticus. If you use benzodiazepines chronically for epilepsy, it stops working and the patient can develop tolerance to these agents in the same way that they develop tolerance to the sedation. These agents can stop working to prevent epilepsy. In this photo, you can see a device that's used to rectally administer benzodiazepine, and this administration route can be especially helpful in children who are in the middle of status epilepticus. It can be really difficult to administer an agent to a child who is having chronic, nonstop seizures, either through an IV or orally. So this device is really helpful. And this device is also developed here at Minnesota. It's where the initial studies were done. Gabapentin is another anti-epileptic agent, and it has side effects including CNS issues, dizziness, drowsiness, and visual changes. Unlike most of the other medications, it is not metabolized by the liver. One downside to gabapentin is that it's not really very good as an anticonvulsant. You primarily see it being used for other reasons, including pain disorders, migraine disorders, and neuropathic or nerve pain. The next agent is ethosuximide, and side effects again include a rash and CNS side effects, but these CNS side effects are a little unique from the other agents and can include aggression and nightmares. Ethosuximide is also metabolized by the CYP enzymes, so you need to be sure that you're looking at other possible drug interactions. Topiramate has a pretty consistent adverse event profile. Side effects can include headaches, but this agent is actually also used somewhat commonly for the prevention of migraine headaches, so it just depends on the person. There also can be dramatic weight loss with topiramate, and it is now actually being used alone and in combination with other medications for weight loss specifically. It's believed to work for weight loss because it significantly decreases a patient's appetite, so they do not feel like eating as much. If we talk about the benefits of the newer agents, it's usually that they are generally easier to take, meaning they might have a more convenient dosing schedule, less side effects, and less drug interactions. Some of the first generation anti-epileptic drugs need to be taken 4 times a day, and some of the newer agents can be taken once or twice a day. The newer agents also don't have blood monitoring. However, the second generation medications often can be more expensive than the first generation medications, and they haven't necessarily been shown to be more effective or to improve the quality of life more than the first generation agents. As you can tell from this presentation, there are quite a few different drug options to choose from. So there are several factors that we take into consideration when choosing a medication. First is choosing based on a particular seizure type that they have. Some medications have indications for specific seizure types, and others we also have documentation from clinical practice of what kind of seizures it's effective for. Some of these agents can actually make specific kinds of seizures worse, so you really have to be careful about that. Although many of these agents share some common side effects, you may choose an agent based on the adverse event profile that would be least disruptive for the patient. For example, if someone was already underweight, you may not want to choose topiramate because it can cause that decreased appetite and you may see more weight loss. Also, you need to think about other patient-specific factors like underlying diseases and other medications that may interact with the anti-epileptic drugs or the financial status of the patient and what they can afford. We think about these decisions with most medications that we select, but especially for seizures, it's important to think about the medication option because it's a very hard disease to treat. And there are so many criteria to choose from, so we really need to think about the individual patient. And then we also have to make sure that after selection that we are monitoring closely and adjusting as needed. A woman who has epilepsy and is pregnant presents a very specific therapy challenge. All of these agents have the risk of teratogenic problems, and many of them fall under Category D, saying that we have documented adverse events when they are used in pregnancy. Some of the newer agents fall under Category C, but if you remember, this sort of means we really just don't know or don't have good evidence yet, so you're still taking a risk. However, there's a big risk of having a seizure while you're pregnant because it can be very dangerous for the fetus, especially due to the risk of potential fetal hypoxia, so it's a very tricky therapy situation. You want to find the greatest benefit and minimize the risk because there is going to be some risk no matter what decision you make. As we've already talked about, seizures are very difficult to control. Approximately 50% of patients will achieve complete seizure control, and an additional 25% will improve significantly but may still have ongoing seizures. It's difficult when you're treating seizures because with almost any patient, we theoretically could push the medications high enough where we would stop all seizure activity, but you need to think about at what cost this is to the patient. As we've learned, many of these agents have CNS effects, often including drowsiness or sedation. So most patients will say that it's not personally worth it to them to be seizure-free if it means they are unable to interact with their friends or family or do their job without significant side effects. So many of them may continue to keep the medication low enough that it reduces seizures, but may not stop them completely so they can maintain normal cognition and an overall higher quality of life. It's important to remember that this is their disease and they can set their own goals, and it's just our job to help them reach their goals. Some patients may become candidates to discontinue their anti-epileptic medications. Typically, they need to be seizure-free for at least 2 years and have other low-risk characteristics that indicate that they are at a lower risk for seizure reoccurrence. Continuing on about discontinuation of anti-epileptic therapy, as we said, they must be seizure-free for at least 2 years and have a low risk for seizure reoccurrence. For example, a patient who started having seizures for no reason is generally considered lower risk than someone who started having seizures from a neurologic injury that would make it more likely that they are at risk to have more seizures. Other factors to look at include if the EEG is normal, if the onset of seizures started as a child, if there's an absence of other neurologic abnormalities, and if the seizure can be controlled with a single agent. All of these factors indicate a lower risk for seizure recurrence if you're considering discontinuing therapy. So if the patient meets some of these criteria and appears to be a good candidate for discontinuing, we want to slowly take the patient off the agent. The brain has gotten very used to having this agent on board for at least 2 years, so we want to slowly acclimate the brain to being free of the drug. If during this slow tapering process to discontinue a seizure happens, then you would want to reinitiate therapy. Patients with epilepsy will initially be prohibited from driving after their first seizure, and the laws vary slightly from state to state. The patient will also undergo a lot of other changes. Along with being prohibited from driving, they may feel out of control and might have a set of their own goals. This is their disease, and the goals of therapy are personal and individual to them. As we mentioned before, we probably could dose someone high enough to stop all seizure activity, but at a cost to quality of life and functioning. Treating this disease can also have impacts on other areas of life because it may be a lifelong therapy. You need to consider especially the tolerability of the therapy, as well as being very aware of drug interactions and educating the patient on checking drug interactions for all new medications they may want to start, especially including over-the-counter medications and herbal supplements. The last 2 slides provide a summary of what we discussed in this presentation. First, it's important to remember that most of the agents have some form of CNS effects and multiple drug interactions. Rash is a really common side effect for these agents, and this rash can become a serious life-threatening rash. The 4 agents listed can cause a rash, and remember that the rash with carbamazepine is a delayed rash. Finally, 2 agents require drug level monitoring, and that's phenytoin and carbamazepine. This doesn't mean that you would never monitor the other agents, but it's always done with phenytoin and carbamazepine to make sure that the drug is in the therapeutic range to maximize efficacy and minimize toxicity. Remember that this is a very complicated disease state, and we covered it at a 10,000-foot view. But remember that there are multiple types of seizure disorders and many medications available for treatment. We try to tailor the therapy to the patient's needs and work with the patient to set their own goals with regard to the disease. We monitor these patients very carefully. These drugs are not the easiest to take, so we want to make sure that they are tolerating them well and not going to have an adverse event that may be life-threatening. Remember that pregnancy is a special challenge, and also the length of therapy can be a challenge because many patients will be taking anti-epileptic medications for the rest of their life. As we talked about, some may be candidates for discontinuation, but the rest will be on lifelong therapy.